This is the nervous section. Your 2020 CPT begins with your index, good illustrations to your nerves, the different nerve centers, which are your plexus, brain, different lobes, different parts of the brain. This is very good. The nervous system will start with the top of the body, which is the skull, meninges, and brain. The meninges do run along down the spine as well. There are 3 layers of the brain that I always kind of keep forefront in my mind when I'm looking at stuff in here. Outer layer is the dura mater. The middle layer is the arachnoid. Inner layer is the pia mater. Within this section, you've got this is not quite as consistent as an easy a fit as some of the other organ systems in the CPT. You have your injection, drainage, and aspiration area for this body part. This is where you may have your drill holes or your burr holes. They're gonna, if they trephinate something, they're gonna make a hole. This has some craniectomies and craniotomies in here. Rule of thumb, if you have documentation of a craniectomy and a craniotomy, only code the craniectomy. That otomy, that incision into, would be bundled into a craniectomy. But there are times that they only do a craniotomy. Maybe they just cut in. So that would be appropriate. 2 words, supratentatorial and infratentatorial. That is, supra means above, so that is above the cerebellum. Infra means below, so that is below the cerebellum. I keep that written in there. Skull surgeries, that type of thing is not anything that I routinely do on a daily basis. So if I were going to work this area, I would probably have to go back to my 321 coded book and read these sections again and kind of go over the examples for coding in here. I will say your 321 coded book, this nervous system section in it is excellent. It really does break it down little chunks at a time that we're just not able to do as easily in a video like this. Skull-based surgery. The best way to code in here is to kind of take the guidelines as they have it. They've numbered it for you into 1, 2, 3 steps. Most skull-based surgeries will have 3 steps to them, most of them. So 1 is the approach, 1's the definitive procedure, and 1's the repair. And so I just kind of keep flowing with that 1, 2, 3, and like, here's my approach, 1, there's my definitive procedures, 2, and then I have 3 over here. So that I can, my eyes know, okay, my guidelines told me there's 3 steps, so here's the first step. Okay, so I'll just tackle that one now, then I'll worry about the second step in a minute. That kind of a thing. So you do need to, with the approach, you have an anterior, a middle, and a posterior. So it further breaks it down, needing to know the approach. Definitive, again, it's broken down again. There's a base anterior, base middle, and then a base posterior. Then we have repair codes, and there's just 2 repair codes. So that makes it a little bit easier. So this section, really technical, high level type of surgeries going on here. This is not something you would routinely see, but it's there nonetheless. Endovascular therapies is a little bit of a catch-all, again, like several places are. I know by now you hate me saying catch-all because they're just stinky places, but that's just the way they are. At least not all the sections are stinky. This most in here is either dilation, balloon dilation, transcatheter placement, fixing occlusions, that kind of thing. Now we get into a little bit more specific. So this is skull surgery, brain surgery, specific to vascular disease, aneurysms, something like that, AVMs. Stereotaxis is a stealth. That's generally, they use different different techniques, but they're doing it through stealth. So it's very slow, methodical, with the least bit of resistance type of thinking in here. If you do have stereotaxic CT localizations, I have a note here, you're going to need to use code 77011 in addition. This note up here is just telling you what I've already told you. If you have a craniotomy and a craniectomy at the same time, only code the craniectomy. Your stereotactic radiosurgery, this is radiation. All of this, so I just wrote radiation. Now we're getting into some of the neurostimulators being placed. Again, this stuff is very, very, very technical, very specific, which helps you once you get an idea of what you're dealing with. Cerebrospinal fluid shunts. So if maybe you even in risk adjustment, we see normal hydrocephalus, and a lot of those older patients have shunts put in because they just have too much cerebrospinal fluid. This is a example of having a shunt put in, and then along the tube being placed, and then it drains all of this extra cerebrospinal fluid down into the abdominal cavity, and then your body just naturally metabolates that fluid out. Now we're into the spinal cord. So in this area, like several different areas, number one, you need to know your definitions: percutaneous, endoscopic, open, indirect, direct visualization. I also have 4 pieces of information you need to try to glean out of the op report in order to capture everything you need. Number one, you've got, this is spine and spinal cord. You've got to know your anatomic site within this. Are you dealing with cervical spine, thoracic spine, lumbar spine, sacrum? What are you dealing with? Whatever is happening, is it diagnostic or therapeutic? What's the type of substance, and is it a continuous drip? Continuous, like an epidural, something like that. So that's this section. Catheter implantation down here. And again, I hate it when they start, but the actual codes are on the other page. That is so difficult, in my opinion. You need to code also for the actual placement of the catheter, and it tells you to do that. We're still on the spinal cord. Now we're getting into some of the back surgeries. Not necessarily on the vertebrae, but this is probably, most everything is going to be your discs, your nerves, that kind of thing. Remember, this is nervous system. Again, if you have laminotomy and laminectomy in the same procedure, code only the laminectomy. And here you're going to need to know your approaches. So this is posterior, laminectomies and laminotomies. Really watch your eyes for those suffixes. I underline them. You can see laminectomy, laminotomy. This is a different approach. This is through the ribs, more of a side approach, posterolateral. Then your anterior approach. Here is another note. A corpectomy, corpo meaning body, corpectomy includes a discectomy. Corpectomy includes discectomy. In here is probably where you're going to find your discectomies. Remember when we were in the musculoskeletal and we were talking about the spinal fusions and we connected to an area in the nervous system? This is the area. So I have connected this area back to my musculoskeletal. So code also the arthrodesis, which is back in the musculoskeletal if it is done. And that's how I connect the two. Just more specific type of stuff, laminectomies other than herniated discs. They're very specific. Your stereotactic radiosurgery, this is that radiation again. Neurostimulators of the spine, not the brain. So always know your body parts or what you're dealing with, because you may have some of the same sections, but it's on a different body part. Cerebrospinal fluid, spine, not of the brain, not the cerebrospinal fluid that's in the brain. In this area are your different nerve blocks, injections. If you see the word nerve block, that means regional block. Nerve block is a regional block. I don't know that it matters to track whether they're voluntary movements or not. I don't even have any idea why I started doing that, but I did. This is a very good table of the different injections, and you can plug in very easily into this table and not have to follow along in the actual columns. This is a nice addition, in my opinion. This sums up most of these pages. Then we have neurostimulators just on the peripheral nerves. So now we have neurostimulators 3 times in this section, 1 on the brain, 1 on the spinal cord, and 1 of the peripheral nerves. We have destruction of nerves. Once they're destroyed, they don't come back, but that's what this is. Neuroplasty, neuro meaning nerves, plasty, surgical repair. Transection or avulsion of nerves. Raphe, neuroraphe. So raphe means suturing, so this is sewing up of nerves. And that's it. That's the section. So let's do a little bit of drilling in here. Very technical. I find nervous system to be more technical than the cardiovascular. But if you can really always drum down to your body part, at least that cuts out 1/3 or 1/4 of the section. You know, it does help, I promise. You just have to get in here and read the codes and make your notes. Okay, so let's see, what are we going to do? Let's put in some burr holes. Burr holes were created and a ventricular reservoir was implanted. So burr holes, where would burr holes go? In the skull. So we know we're in the right place. Here's our burr hole area. So at least we only have 15 codes to look through. So we're doing burr holes for, and then a placement of a ventricular reservoir. So here's burr holes for ventricular puncture. Nope, that's not right. Burr holes or trophine, which is making a hole for biopsy. That's not right. Burr holes for evacuation and drainage of hematoma. Nope, that's not right. Burr holes of aspiration. Nope. Burr holes for implanting ventricular catheter reservoir. Now we're talking. So that's it. So that's our code, 61210. So we did burr holes to the semicolon, then for implanting ventricular catheter reservoir. That's it. See, that's not, if we break it down, it's not too bad. Just hearing it, whoa, it's daunting. But that's not too bad. That's not too bad. Okay, physician aspirated shunt tubing. So he aspirated, that makes me think introduction or other procedures right there. Aspirated shunt tubing. With a needle. So this is done per a needle. So, aspirated shunt. We don't necessarily know if that shunt is in the head or where. Let's say it's in the head. If you had your note, it would be better. So let's go on. And sometimes the scenarios that we get aren't the best. We have to do some assuming, and it's never a good scenario to have to assume. So since this is an aspiration, that's like a drainage. So let's look in here and see what we can get. Ventricular puncture, cisternal puncture of shunt tubing for aspiration or injection of procedure. So that's it. 61070. Very good. Good. Okay, let's do another one. Let's do decompression. Oh no, let's do removal of the lamina. So removal of the lamina, that is actually, if we take those words, that is a laminectomy. Removal means ectomy, lamina, lamin. So that's a laminectomy. Removal of lamina and insertion of lumboperitoneal. Boy, I hope I'm spelling all this stuff right. You guys don't think I have no idea what I'm doing. Shunt for drainage. Of extra cerebrospinal fluid. Okay, so they've done a laminectomy, or they've removed the lamina, and they've inserted a lumboperitoneal shunt for drainage of cerebrospinal fluid. So we've got to get to our body part. Gotta keep going. Too far. Where is our... So I got to make sure I'm on my back. Let me just go back. I'm sure I am. I just want to show you. So here I'm in my spine. That's where I need to be. Lamina is not in the head anymore. So we came into the back. We're doing stuff with cerebrospinal fluid. So I'm going to start here, hoping I'm right. That's how I put that together. We'll see. So we've inserted a lumboperitoneal shunt for drainage of cerebrospinal fluid. So creation of shunt, lumbar. So there's our lumbo. Peritoneal. So this is going from subarachnoid. So this is going from the brain, draining the extra cerebrospinal fluid down into the peritoneum. And it includes my laminectomy. So that's my code, 63740. 63740. That one was interesting. Let's do another one. Let's do a nerve block, because this would be pretty common. And where are we doing that nerve block? We're going to do that nerve block to the axillary nerve. Okay. So we have to get out of the spine and into our extracranial nerves, where all of our, remember this is where a table is, so this is where this would be. So now I need to find my axillary nerve. So this table is not going to help me with this specific nerve. So I've got to find my, so there's my greater occipital, Let's see, this is an injection of anesthetic agent. That's why they would be doing a nerve block for pain control. So I just have to find my axillary nerve. So vagus nerve, brachial nerve, axillary nerve. There it is. 64417. Good job. So that is the nervous system. You guys just have one more section of the CPT, and then we're out of the surgery section, and we just have a few more, and then you will have whipped the CPT. So see you on the next video.